This combination of OX40 and PD-1 has been tried before, and I believe even in some clinical trials, it's been used for solid tumor malignancies. And this was a very difficult problem to address. Basically, we took one of the most challenging tumors, pancreatic cancer, used it in, again, a fairly rigorous model, orthotopically transplanted PDAC model, pancreatic cancer model, as well as a genetically modified KPC model, which most of you are familiar with, developed in Tubis and Slab and others. The reason why we pursued this was because it seemed like if we had a clear result, it would be obvious this was only attributable to how the mice were treated and manipulated. What's important to understand here is that there was no vaccine. There was no adoptive transfer. This was strictly the use of an agonist, in this case OX40, together with an immune checkpoint inhibitor, PD-1. We had tried various combinations. None of them really worked. This worked the best. Essentially, this model involved orthotopic transplant of luciferase engineered pancreatic tumor cells, so we could follow this fairly precisely over several weeks, months even, to ensure that whatever we did in these tumor-bearing mice before treatment and then after treatment led to pretty much complete tumor eradication in that cohort, which received a combination of OX40 and PD-1. OX40 alone did not do it, PD-1 alone did not do it, and CTLA-4 plus OX40, CD137 and OX40, and we tried several combinations, did not achieve these results. And having achieved those results, demonstrated, in fact, that this was first T-cell mediated, that both CD4 and CD8 T-cells contributed to rejection of this pretty difficult to treat tumor in these mice, and that finally that the CD4 and OX40 contributed to long-lasting memory. In fact, we could transfer these to other mice and protect them. If you did not include OX40, if you depleted CD4, you did not have memory. And in fact, the mice that were cured 3-4 months later, re-challenged, these mice rejected those tumors in most cases. We even treated them with a more aggressive pancreatic tumor, MT4, at that point, showing a way that there were shared, presumably, antigens, which were generated in the initial challenge and then recapitulated in the memory challenge. I think what this study shows is, first of all, don't give up hope on OX40. Don't give up hope on OX40 PD-1, although clinical trials may say differently. I think a lot of it has to do with the agonist activity of the OX40, perhaps the timing, and most importantly, the immunogenicity and ability to generate memory. So we're delving into those details more in single-cell sequencing analysis, hopefully have another paper out describing a little bit deeper dive some of those intrinsic mechanisms. I think that pancreatic cancer is, and I've hoped that we can do something about this statistic, as becoming one of the most lethal cancers, if not the most lethal cancer for patients afflicted with this disease. And not only that, I think it's also becoming more and more common, which is unfortunate and surprising. But I think what we have now are various different tools. You could certainly combine OX40 and PD-1 with adoptive cell therapy, now that we have a whole slew of pancreatic cancer antigens. We can then probe and understand if that fails, why it fails. Is it because of TGF-beta environment? Is it something else? Is it the MDSCs? But each one of these is just a building block, taking a step towards an ideal combination for perhaps, a given tumor or even a given individual. So just another arrow in our quiver.